So thank you everyone for joining us today for the Kirby Institute seminar series. My name's Lisa Ma. I'm the head of the Viral Hepatitis Epidemiology and Prevention program here at the Kirby Institute. I'd like to start by acknowledging the traditional custodians of the different lands from which we gather today and the continuing connection to culture, land, sea, water and community of Aboriginal and Torres Strait Islander people. I'm joining you today from the traditional and unceded lands of the Bidjigal people and pay my respects to elders past and present and extend that respect to all Aboriginal Torres Strait Islander people joining us today. The format for the seminar will start off with the presentation followed by a Q&A at the end, and you can ask questions throughout by clicking the Q&A icon at the bottom of the screen. So it gives me pleasure to introduce Louise Geddes, who's a research assistant in my program here and also a almost a newly minted PhD at the Kirby Institute. Louise currently works on the New South Wales Needle and Syringe Program Enhanced Data Collection Project, which collects data from people attending NSPs in New South Wales. She completed her undergraduate degree in health sciences at the University of Sydney and also holds a master's in immunology and infectious diseases and a master's in international public health from the University of Sydney. Prior to joining us, Louise worked in Uganda at the Medical Research Council on a project exploring the impact of HIV on older people. Her current research interests include opioid use among people who inject drugs. So I will turn it over to you, Louise.
Would like to begin today by acknowledging the Darug people from where I live and am presenting from today, and pay my respects to the elders past and present. Today I will be presenting the research conducted as part of my PhD, which investigated the health-related harms associated with the illicit opioid injection. So globally, the prevalence of injection drug use is 0.3%. And this ranges by region from 0.1% in South Asia to 1.3% in Eastern Europe. Prevalence of opioid use and injection has increased significantly over the past 2 decades. And in 2017, opioids were the main drug injected, estimated to be injected by 82.9% of people who inject drugs. One of the regions where the rise in opioid injection has been most evident is in North America, particularly in the United States. The current epidemic in North America began in the early 1990s, following the release of the sustained release formulation of oxycodone named OxyContin by Purdue Pharmaceuticals. The epidemic in the United States can be broken down to 3 distinct phases. This graph shows the overdose deaths involving opioids in the United States between 1999 and 2019. Here in the first phase, we can see the increase in opioid deaths due to pharmaceutical opioids. In the second phase, we can see the rise in deaths due to heroin. And in the third phase, we can see the significant rise in the number of deaths due to synthetic opioids. So fentanyl is a synthetically produced opioid that's about approximately 100 times stronger than morphine. Illicitly manufactured fentanyl refers to opioids containing non-pharmaceutical opioid. And due to its high potency, fentanyl and illicitly manufactured fentanyl are increasingly being added to low-grade opioids and other psychoactive substances. And to show the dramatic rise in the deaths due to synthetic opioids, in 2009, just over 36,000 people in the US died from an overdose, including synthetic opioids. And that was nearly 12 times the number recorded in 2013. Opioid injection in Australia has historically involved heroin. Unlike North America, strict regulation of pharmaceutical opioids has prevented the overprescribing of these drugs. However, between 1995 and 2015, the annual number of opioid prescriptions in Australia has increased 15-fold. Fentanyl that is injected in Australia is mainly diverted from prescribed medication. It's predominantly transdermal patches. And while there have been reports of some illicit manufactured manufactured fentanyl being added to stimulants, so it's methamphetamine and cocaine. Illicitly manufactured fentanyl has not yet widely penetrated the illicit Australian drug market. One of the main harms associated with the injection of opioids is HIV. In 2017, it was estimated that 2.8 million people who inject drugs were living with HIV, and this equated to a global prevalence of 17.8%. Each year, injection drug use accounts for approximately 10% of all new HIV infections. But HIV testing remains subpar among people who inject drugs. And in 2017, it was estimated that only 1% of the global population of people who inject drugs live in a country where HIV testing coverage is considered to be high. Additionally, despite the known benefits of antiretroviral treatment in preventing transmission of HIV, in 2017, it was estimated that only 4% of people who inject drugs who were living with HIV were receiving antiretroviral treatment. Hepatitis C is another blood-borne virus associated with the injection of opioids. And in 2017, among people who inject drugs, hepatitis C exposure, which was the prevalence of hepatitis C antibodies, was estimated to be 52.3% globally. It has been demonstrated that compared to their male counterparts, females who inject drugs have a 38% higher risk of acquiring hepatitis C. Females are also more likely to spontaneously clear their infection, suggesting that sex plays a role in the natural history of hepatitis C. The prevalence of recent hepatitis C testing among people who inject drugs is estimated to be 61% globally. By the end of 2019, approximately 9.4 million people had been treated for hepatitis C using direct-acting antiretrovirals, and this included approximately 90,000 people in Australia. Uptake of direct-acting antiretroviral treatment in Australia has resulted in the proportion of people with active infection declining from 44% in 2015 to 17% in 2019. The third health-related harm I'll be discussing today is opioid overdose. Opioids interact with three subtypes of receptors, the mu, the delta, and the kappa, located throughout the central nervous system and peripheral nervous system. Activation of these receptors by opioids causes the depression of neuronal firing and subsequent depression of the respiratory system, which can result in overdose. An opioid overdose is a major cause of mortality worldwide. So of the 500,000 deaths worldwide that are attributed to drug use each year, approximately 350,000 are related to opioid use, and that includes approximately 110,000 that are due to opioid overdose. However, not all overdoses result in death, with non-fatal overdoses far more prevalent than fatal overdoses. And it has been estimated that the ratio of fatal to non-fatal heroin overdoses is 1:31. Each year, approximately 3.2 million people who inject drugs experience at least one non-fatal overdose that year. And it has been further estimated that 6.4 million people who inject drugs have a lifetime history of non-fatal overdose. It is important to monitor non-fatal overdoses among people who inject drugs because lifetime history of overdose is a predictor for future fatal overdose, and a dose-response relationship exists between non-fatal and fatal overdose. For non-fatal opioid overdoses in particular, one key risk factor is the concomitant use of other central nervous system depressants, such as alcohol and benzodiazepines, as these drugs further reduce the depression of the central nervous system. To mitigate the harms associated with the injection of opioids, a suite of harm reduction responses are available. The World Health Organization recommends that a comprehensive package of these interventions be implemented to reduce the transmission of bloodborne viruses, as well as reduce the number of deaths due to overdose. Some of these interventions include needle syringe programs, opioid agonist therapy, supervised injecting facilities, and naloxone. Despite the recommendation that these responses be implemented to reduce these harms, it was estimated in 2017 that only 1% of people who inject drugs globally live in a setting where there are sufficient interventions. Furthermore, implementation of these interventions has plateaued in many countries, and in some countries, particularly those in Asia, Africa, Central and Latin America, where there have been punitive responses to drug use, declines in the availability of interventions have recently been observed. So, for example, the number of countries that provide needle and syringe programs has stagnated recently, with a decline from 90 countries operating needle syringe programs in 2016 to 86 in 2020. Needle syringe programs aim to reduce drug-related harms such as injection-related injuries and diseases and bloodborne viruses through the sufficient coverage of sterile injecting equipment. A systematic review and meta-analysis by Platt et al. Found that needle syringe program coverage was associated with a 56% reduction in the risk of hepatitis C acquisition. Global targets for the needle and syringe coverage have been set by the World Health Organization, UN-AIDS, and UN Office on Drugs and Crime, and define needle and syringe coverage as either low, moderate, or high. However, Lani and Peacock's systematic review and meta-analysis determined that of the 57 countries where there was data available, the majority of countries had low range coverage, 12 had moderate, and only 9 countries had high coverage. So opioid agonist therapy, which consists of the full agonist methadone, the partial agonist buprenorphine, and with or without the antagonist naloxone, is the most effective and evidence-based treatment for people with opioid use disorder. Despite its inclusion in the World Health Organization's list of essential medicines, in 2020, opioid agonist therapy was only available in 84 of the 79 countries where injection drug use was known to occur. So in Australia, approximately 53,000 Australians were receiving opioid agonist therapy in 2019, and this represented a 4.7% increase from 2017 and a 15% increase from 2011. Opioid agonist therapy prescription has been shown to halve the risk of death among people with opioid use disorder, and that's from both all-cause mortality and mortality due to overdose. Opioid agonist therapy has been associated with a reduction in the transmission of bloodborne viruses among people who inject drugs. So a systematic review and a meta-analysis by Platt et al. Found a 50% reduction in the risk of acquiring hepatitis C among people who reported injecting drugs and who were prescribed opioid agonist therapy. There was also a 19% reduction in people who injected drugs who had a lifetime history of opioid agonist therapy. However, this review also observed a discrepancy between males and females and found that there was a 59% reduction in effectiveness for every 10% increase in female participants. However, the benefits of opioid agonist therapy are only observed when people who inject drugs are retained in treatment, and a linear relationship between the length of time an individual is retained in opioid agonist therapy and optimal health and social outcomes has been observed in several studies. So there were 4 aims to the research I conducted as part of my PhD. They were to, 1, describe the characteristics of Australian people who inject drugs, who report recent fentanyl injection, and to identify the independent predictors of recent fentanyl injection. The second was to estimate the prevalence of multiple non-fatal opioid overdose among people who inject drugs in Australia, and to ascertain the correlates of recent multiple non-fatal opioid overdose. The third was to determine the incidence of opioid agonist therapy discontinuation among Australian people who inject drugs, both overall and pharmacotherapy specific, and to identify factors independently associated with discontinuation. And the last was to assess the differences in hepatitis C incidence by sex among an international cohort of people who inject drugs exposed to opioid agonist therapy, and to identify factors independently associated with any decrease in protective efficacy. So the aims of this research were achieved by using 2 data sources. The first being the Australian Needle Syringe Program Survey, referred to as the ANSPS. The ANSPS is a biobehavioural sentinel surveillance system that's conducted annually and was established in 1995. Each year, approximately 2,500 needle syringe program attendees participate in the ANSPS. And participation involves the completion of a self-administered questionnaire and the provision of a dried blood spot sample. The ANSPS is conducted at approximately 50 needle syringe programs across Australia each year, and it's a mix of both metropolitan and rural regional settings, as can be seen to the map on the right of the slide. Finally, the ANSPS has been shown to be representative of people who inject drugs who attend primary needle syringe programs in Australia. So here we just have a couple of photos from the ANSPS. The second data source utilised in this research was the international collaboration of incident HIV and hepatitis C in injecting cohorts, referred to as InC³. InC³ was the first global collaboration of 10 prospective observational studies of HIV and hepatitis C from 4 countries. And InC³ was established to facilitate new studies that could not be conducted within the existing cohorts. Data included in the InC³ varies between each of the cohort studies, but not within each study. And each cohort varied in exposure times, sampling frames, and follow-up intervals. Data included in InC³ includes demographic characteristics, injecting behaviour, sexual behaviour, imprisonment information, and treatment for drug use, as well as serological and virological data. So it's HIV and hepatitis C antibody and RNA, as well as other biological markers. Ethical approval was obtained from local institutional research review boards. So study 1 of my research investigated intravenous fentanyl use among people who inject drugs in Australia, and the corresponding manuscript can be found in Drug and Alcohol Review. About the methods for this study, supplementary questions on injection of pharmaceutical opioids were included as part of the 2014 ANSPS. Respondents were provided with a list of pharmaceutical opioids commonly injected in Australia and were asked to answer a range of questions regarding the injection of these opioids. The primary outcome was recent fentanyl injection, and logistic regression models were used to calculate the crude and adjusted odds ratio and 95% confidence intervals. So a total of 193 respondents reported recent fentanyl injection in 2014, and this equated to 8% of all ANSPS respondents that year. When it was restricted to only those who reported the injection of a pharmaceutical opioid, this equated to 23%. Of the 193 respondents who reported recent fentanyl injection, 37% reported that fentanyl was the main pharmaceutical opioid that they had injected during this period. So from this table, we can see that those respondents who reported recent fentanyl injection were predominantly male, had a median age of 39 years, and had completed the ANSPS at a metropolitan needle and syringe program. This table shows the factors associated with recent fentanyl injection. So Indigenous respondents were 1.6 times more likely to report fentanyl injection in the previous 6 months, while those who reported daily or more frequent injection were 1.9 times more likely, and those who reported public injection were 1.4 times more likely. Additionally, participants who reported that they had experienced an overdose in the last 12 months were twice as likely to have injected fentanyl compared to those who had not reported an overdose. Study 2 of my research aimed to determine the prevalence of multiple non-fatal opioid overdose among people who inject drugs in Australia, and the corresponding manuscript can be found in the International Journal of Drug Policy. About the methods for this study, so supplementary questions regarding non-fatal opioid overdose were included as part of the 2019 ANSPS. Respondents were asked a range of questions regarding their last non-fatal opioid overdose. The primary outcome was multiple non-fatal opioid overdose in the previous 12 months. And logistic regression models were used to calculate crude and adjusted odds ratio and the 95% confidence intervals. So a total of 2,609 respondents completed the ANSPS in 2019, of which a total of 222 respondents completed the supplementary questions and were eligible for inclusion in the study. Of the 222 respondents who completed the supplement, 48% reported that they had experienced multiple non-fatal opioid overdoses in the previous 12 months. And we can see from this table that the respondents who reported multiple non-fatal opioid overdoses were predominantly male, with a median age of 41 years, and just over half were hepatitis C antibody positive. So this table shows the non-fatal opioid overdose characteristics of respondents included in the study. So the median number of non-fatal opioid overdoses among people who reported multiple were 3. The median months since the last opioid overdose among all respondents was 3 months. However, was 2 months among those who reported multiple overdoses and 6 months among those who reported a single overdose. Drug-related reasons were the most frequently nominated belief as to the main cause for their last non-fatal overdose. This was followed by the contamination of drugs injected and the belief that the opioid they had injected had been contaminated. Smaller proportions of respondents reported that their tolerance had been lowered or that they had used benzodiazepines or consumed alcohol prior to their last overdose. 11 respondents reported that their last non-fatal opioid overdose was intentional and or a suicide attempt. Provision of naloxone was the most common treatment received, and this was followed being taken to hospital where naloxone may or may not have been administered. And approximately 1 in 4 respondents reported that they received no treatment at their last non-fatal overdose. Multivariate analyses indicated that respondents who reported benzodiazepine use were 2.7 times more likely to have reported multiple non-fatal opioid overdoses. And respondents who reported that their last non-fatal opioid overdose had occurred in a public location were twice as likely to have reported multiple overdoses. Study 3 of my research aimed to determine the incidence of opioid agonist therapy discontinuation among people who inject drugs in Australia and the factors associated with discontinuation. This corresponding manuscript can be found in Addiction. About the methods for this study, ANSPS data that was collected between 1995 and 2018 was utilised. Repeat respondents were identified using a simple deterministic linking method, and respondents were included if they reported being currently prescribed opioid agonist therapy at any survey participation and had subsequent participations where this data was available. The primary outcome was discontinuation of opioid agonist therapy, and follow-up time was estimated using the person-year observation method. Date of discontinuation was calculated as the midpoint between the last survey participation where current opioid agonist therapy was reported and the next survey participation where current opioid agonist therapy was not reported. Overall, and pharmacotherapy specific discontinuation rates were determined using Kaplan-Meier methods. Cox proportional hazard models were used to determine predictors of opioid agonist therapy discontinuation, along with an adjusted hazard ratios and 95% confidence intervals. This slide shows the respondent inclusion flowchart. Between 1995 and 2018, just over 55,000 needle syringe program attendees participated in the ANSPS. From this, matching key was created for 5,390 individuals, of which 2,651 individuals reported current opioid agonist therapy at any survey participation and had subsequent survey participations and were therefore included in the study. Of the 2,651 respondents included in the study, 760 reported a discontinuation event, and that equates to a 1 in 3 respondents. This table shows the sample characteristics of respondents who reported a discontinuation event. We can see that 2/3 of respondents were male, had a median age of 34 years, and 2 in 3 respondents were hepatitis C antibody positive. This slide shows the Kaplan-Meier survival graphs, both overall and pharmacotherapy specific. The overall incidence of discontinuation was 6.3 per 100 person years, and pharmacotherapy specific incidence of discontinuation ranged from 5.7 per 100 person years for methadone to 9.0 per 100 person years for buprenorphine. This table shows the factors associated with the discontinuation of opioid agonist therapy, and we can see that discontinuation was significantly higher among respondents who were male, those who reported being incarcerated in the previous 12 months, who last injected a pharmaceutical opioid, who reported injecting daily or more frequently, and who were prescribed either buprenorphine or buprenorphine naloxone. Continuing on with response, respondents who reported public injection or the receptive use of syringes or other drug preparation equipment were significantly more likely to report a discontinuation event. Conversely, respondents who identified as homosexual or who had reported an injection history of 15 years or more were significantly less likely to report discontinuation of opioid agonist therapy. Study 4 of my research aimed to examine the sex discrepancies in the protective effect of opioid agonist therapy on incident hepatitis C infection. The corresponding manuscript can be found in Clinical Infectious Diseases. About the methods for this study, so data from InC³ was utilised, however 3 cohorts were excluded from this study. Participant inclusion criteria was that biological sex was recorded as either male or female. Participants had to be hepatitis C antibody negative at baseline. They had to have 2 or more study visits, and they had to report recent opioid agonist therapy on at least 1 visit. The primary outcome was incident hepatitis C infection while engaged in opioid agonist therapy. Time since study enrollment to the date of incident hepatitis C infection was used to calculate person year observation time. And participants who did not record a positive incident hepatitis C infection were censored at the last recorded cohort visit where laboratory results were available. Female and male hepatitis C incident rates were determined using Kaplan-Meier methods, and Cox proportional hazard models were used to determine crude and adjusted hazard models. So this table shows us the sample characteristics at baseline for the study. The majority of respondents were male, white, with a median age of 26 years, and 19 respondents were HIV positive at baseline. A total of 3,003 observed visits were recorded by the 701 participants who were exposed to opioid agonist therapy and included in the study. Over 1,427 person years, there were 148 incident hepatitis C infections recorded, and 74 were in males and 74 were in females. And this resulted in a hepatitis C incidence of 16.5 per 100 person years. The female to male adjusted hazard ratio was 1.8. This table shows the factors associated with hepatitis C incident infection by sex. Among females, non-white race, unstable housing, injecting daily or more frequently, and receptive syringe sharing were all associated with increased hepatitis C acquisition. So the discussion, the 4 studies presented here investigated the harms associated with the injection of opioids, along with the harm reduction interventions employed to reduce their impact on people who inject drugs in the context of a global opioid epidemic. My research has also identified key subpopulations of people who inject drugs, including those who are at a significant risk of harm due to opioids, and for those for whom harm reduction interventions as currently implemented are neither acceptable nor optimal. The findings from study 1 demonstrated that in the overall ANSPS sample, 1 in 10 respondents reported recent fentanyl injection. Factors associated with recent fentanyl injection included Indigenous status, daily or more frequent injection, and public injection. Indigenous status is a finding of concern given the higher rate of unintentional drug-induced deaths among this subpopulation, And in 2019, the drug-induced death rate among Indigenous Australians was 2.5 times that of non-Indigenous Australians. This highlights that there is a specific need for tailored harm reduction services that are sensitive to the specific cultural and community needs of Indigenous people who inject drugs. Explained by the short and euphoric effect experience when injecting fentanyl. And this requires an individual to inject fentanyl more frequently. It has been hypothesized that a recent increase in HIV cases in Maryland in the US may be due to an increase in the injection of fentanyl in the area. Findings from study 2 indicated that multiple non-fatal opioid overdose were prevalent among ANSPS respondents, with 1 in 2 respondents reporting multiple non-fatal opioid overdoses. Factors associated with multiple non-fatal opioid overdose were concomitant use of benzodiazepine and public injection. Public injection has been shown to be prevalent among more vulnerable and marginalized subpopulations of people who inject drugs, and this includes people who inject in public. Supervised injecting facilities are designed to provide a safe environment for people who inject drugs to inject, and people who report public injection are a key target population of supervised injecting facilities. Concomitant use of benzodiazepines are a known risk factor for opioid overdose. Benzodiazepines enhance the agonist effect of opioids and increase opioid serum concentrations, resulting in an increase in the rewarding and analgesic effects of opioids. However, this knowledge may not result in a reduction in the risk behavior by some people who inject drugs. So along with education, we need to provide other harm reduction interventions such as naloxone and supervised injecting facilities for this subpopulation of people who inject drugs. Findings from study 3 showed that approximately 1 in 3 ANSPS respondents reported a opioid agonist therapy discontinuation event. And this is comparable to international studies, and one in particular which found that 39% of Austrian opioid agonist therapy recipients had discontinued treatment. The study found that male sex, daily or more frequent injection, public injection, and receptive syringe sharing were associated with a discontinuation of opioid agonist therapy. Out-of-pocket costs for the individual represent a major barrier to retaining individuals in opioid agonist therapy programs. And so expanding no or low cost opioid agonist therapy could increase retention in programs. Interestingly, prior to COVID, most opioid agonist therapy in Australia was provided via daily supervised dosing, and takeaway doses were only available for those who were deemed to be low risk of diversion. However, as a result of the public health measures that have been introduced, many opioid agonist therapy services have had to modify their services. And this includes an increase in the availability of telehealth, an increase in the availability of takeaway doses, and the increased use of depot buprenorphine. Finally, there's findings from study 4. It was found that females who inject drugs who were exposed to opioid agonist therapy were 80% more likely to acquire hepatitis C. And among females, non-white race, unstable housing, daily or more frequent injection, and receptive syringe sharing were all associated with hepatitis C acquisition. There are a couple of possible biological explanations for this, and that includes differences in opioid receptor binding between males and females, and hormone levels which may hamper the binding of opioid agonist therapy and therefore affect the dosage required for females. There are also social and structural explanations for this finding, and that includes higher rates of receptive syringe sharing among females who inject drugs, and the increased likelihood of females being injected by others, and the fact that gender neutrality of services may actually hamper the ability for females to access healthcare services. So several recommendations and future directions came from this research. Firstly, there is a need to establish a surveillance system in order to detect illicitly manufactured fentanyl in the illicit Australian drug supply. One way to to monitor the presence of illicitly manufactured fentanyl would be to conduct drug testing using fentanyl test strips and to provide these in services accessed by people who inject drugs. Secondly, the availability of low threshold opioid agonist therapy programs in Australia needs to be expanded. This includes the dispensation of opioid agonist therapy at no or low cost to the individual, increasing the flexibility in dosing, increasing the availability of takeaway doses, abolishing drug screening, and increasing the number of prescribers and dispensers. And this is especially true in rural and regional areas. Thirdly, people with severe opioid use disorder who have failed first-line opioid agonist treatment need to be provided with access to supervised injectable opioid treatment. Fourthly, the number of supervised injecting facilities needs to be increased, and this increase needs to be in areas where the need is greatest. Fifthly, we need to improve the data collecting regarding overdose, and this is both internationally and domestically. Furthermore, we need to disaggregate overdose data, especially when it comes to target populations. So this is non-injectors versus injectors, and drug injectors, so opioids versus other psychoactive drugs. Finally, further research is required to elucidate the role of biological and genetic markers and the social and structural barriers in regards to the natural history of hepatitis C and the efficacy of harm reduction interventions. So just as a couple of acknowledgements, I'd like to thank my supervisors, and that's Professor Lisa Maher and Dr. Jenny Iverson. I'd like to thank all the participants of the ANSPS and InC³ cohorts. I'd like to thank my co-authors, especially Hand and Wand, who jumped in and helped on some of the analyses for me. My Kirby and VHEP colleagues, especially Sue, Rachel and Hal, and my friends and family.
Thanks so much, Louise. That was a great presentation, very comprehensive, and yeah, some great research to come out of that study, including some great publications as well. Don't think we've got any questions, so maybe I'll start. So I guess just in terms of implications, or yeah, what we can do, given we've already got, this is in relation to opioid overdose, given we've already got take-home naloxone programs and the long lead time that it takes to establish supervised injecting facilities, what else can we do to try and prevent or manage opioid overdose in this population?
Yeah, so there has been a novel intervention that was introduced in Canada, and they're overdose prevention sites. And so they're very similar in some respects to safe supervised injecting facilities, in that they provide people who inject with an area or a space to inject, and they provide sterile equipment. And should an overdose occur, they provide naloxone and support for breathing. However, the main point of difference is that where a supervised injecting facility is generally staffed by healthcare workers, so it's doctors and nurses, overdose prevention sites are generally staffed by harm reduction workers, and this can be people with and without a history and lived experience of injection drug use. But there are a couple of advantages to overdose prevention sites, and that is that overdose prevention sites can be established relatively quickly. And in Canada, these sites were often established in services that were already utilised by people who inject drugs. And so they required little capital investment. So that's one thing going forward that we could look at.
Okay, and just to follow up, I guess, in relation to opioid agonist treatment, you've mentioned the cost barriers. How much does it actually cost for people to be, who aren't in a public program, to be picking up methadone or buprenorphine at a pharmacy at the moment?
Yeah, so as you said, if you're not in a public program, which are extremely hard to get into and have long waiting lists, opioid agonist treatment is generally dispensed in private pharmacies. And while the treatment is provided for free under the pharmaceutical benefit schemes, there is a dispensing fee that's often charged by the pharmacy. Now, this fee can vary by site, by state, by region, but a recent study by Tran et al. Reported that the cost to an individual is approximately $185 a month, so it's quite high.
Gosh, yeah, so that's something that you could potentially address immediately.
Yes, yes.
By subsidising private providers for the cost.
And expanding and providing more spots so that people can access it through the public system rather than waiting for a spot to become available.
Okay, and I just, Radha's just asked me to remind people that, yeah, to send through any questions through the Q&A icon, but can't see any questions there. Okay, so I'll ask one more question, I guess, just in relation to fentanyl, which we hear a lot about in the media, both here and internationally. Is this the only synthetic opioid that we should be concerned about?
Oh, definitely not. So fentanyl analogues are one area of concern that are really emerging at the moment. So there's carfentanil, which is 100 times stronger than fentanyl. So it is extremely potent. And the reason why the emergence of these analogues is of concern is that this potency, this really high potency, means that people who overdose may require higher doses of naloxone to reverse the overdose. So in a take-home naloxone kit, people will be provided between 3 and 5 ampules. And this may not be sufficient to reverse the overdose. So even though naloxone may be used, people may still succumb to the overdose. Also, to these analogues, people may not be aware of them and so therefore may inject them. And it's also leading to delays in treatment. So it is a very big area of concern.
Okay, well, I think unless there are, anyone has any burning issues or questions, we'll conclude by thanking Louise for such an excellent presentation, but also congratulations on an outstanding PhD reflected in your examiner's reports. Well done, Louise.
Thank you.
And thank you, everybody, for joining today.